appreciate it. Thank you.
Hey, my pleasure. My pleasure. So, hi, everybody. My name is Hesham Elsharkawy. I practice in US. I have the pleasure to be here with you, and really, I'm honored for the invitation. Thank you very much for the introduction, and looking forward to meet all of you in person. So I practice at Metro Health Pain Center at US Cleveland. I'm the director of Transitional Pain Service and the director of the research at Metro Health, and also associate professor at Case Western. And the subject today about the persistent or chronic post-operative pain. So it is a big subject. It will be very difficult to cover all its aspects in just a small lecture or half-an-hour lecture. So we touch base in many of the main issues, and hopefully you're going to get more interested in this subject, which is very critical in our pain continuum. So I have some disclosure, but nothing is related to the lecture today. So we'll talk about the risk factors, the prevention and treatment strategies, and the core of the lecture is the transitional pain service. So the definition of transitional pain or chronic post-surgical pain is very variable in the literature. There's many definitions, like 6 weeks, 2 months, 3 months, it depends on the source. And the most common definition that most of the experts decided on, it's the pain that developed after the surgical procedure and lasted more than 3 months, which is the most common definition by IASP, the WHO, and the new ICD-11 at US. And this pain, it is localized to the surgical field or project to the innervation territory of the surgical incision or the location of the surgery. And you have to exclude other causes of pain, maybe confuse it, like the definition, that you have to exclude pain that it is due to condition before the surgery, infection, malignancy, or non-union of bone, for example. So the incidence or the epidemiology also is very variable. When you look, for example, to the table, that the incidence is very variable from 5 to 35% or 20 to 50%. And this is mainly because of the definition, as I mentioned, and also says severity. Some will define mild, moderate, severe, but even if you look to the lower incidence of many of the surgeries, the incidence is very high. I will give you like one of the high, the amputation. The lowest incidence of chronic pain after amputation is 30% and up to 80%. Thoracotomy also is very common. Knee replacement, hip replacement. So it's a very common problem. And with aging population, for example, that the total knee, total hip replacement procedures, they're going to go up. We're going to have a lot of those patients. So we'll consider it as a most common surgical complications. So who developed this? Why this? Some patient develop it, some patient does not develop it. So identifying a risk factors, it is very critical. So there is multiple risk factors that identified in many studies over the years, related to genetics, related to psychological makeup, neurological predisposition, so the surgical techniques, use of opioid, definitely, and the pain in adults or in pediatrics. We'll go through some of them in some details. One of the most studied, and it have a lot of evidence that the pre-existing pain and the severity of the pre-operative pain is associated highly with the pain post-operative. Also pre-operative opioid use, female, young, and psychological. One of the big risk factors is the psychological makeup or the psychological situation of the patient. So we'll spend some more time on this because it's a very important. When you see a patient have history or experiencing anxiety, depression, catastrophizing. So catastrophizing, it's a very important characteristics, which mean that the tendency of this patient to exaggerate any negative outcome. It's all the time you see this patient in your clinic that all the time is negative. Even if you offer to them any procedure, or any intervention, any medication, he will tell you it is not working. It will not work, even if he didn't try it. He think everything is terrible, everything is going to be bad, and sense of loss of control, and all the time think about the negative. You don't have to be like a psychologist or psychiatrist to diagnose it. It's very clear to you in your office when you see this patient. The patient are scared about the surgery, scared and focused in the post-operative pain. In the social side, they don't have a social support. In the opposite side, if this patient have a less emotional stress, very optimistic, those patients, you know this, they're going to do well. And amazingly, that the psychological makeup is one of the modifiable risk factors. Can you do a sort of test preoperatively, objective test with a certain score to categorize this patient? And you know this patient is high risk. There's a lot of research and a lot of NIH finding and do a pre-operative sensory testing. But those usually sensory testings are cumbersome, costly, and beyond the clinical use of a daily clinical use. So there is other and well-studied actually measure, which is the fibromyalgia score. So there's many studies, I don't have to go to the details of those studies, that they have those patients fill up like a questionnaire, like a fibromyalgia survey questionnaire and widespread pain inventory. And when the score high, even if they don't have the diagnosis of fibromyalgia, those patients are a predictor of operative pain, psychological stress, and even a predictor of poor outcome from the arthroplasty itself. So this is a simple screening measure that you can screen those patients, and if the score high or they have a fibromyalgia, you can categorize them as risk for developing chronic post-operative pain. So when you see the anxiety, depression, and the catastrophizing, all this go under umbrella what they call a vulnerable brain. So this patient have a vulnerable brain of developing the chronic post-operative pain. So genetics also, there's a many variation in genes, but this is an early in the research. So this go with like a biopsychosocial model of pain. So we're not seeing the human being or this person as just like a one piece with the surgery, with the incision, with the physiological factors or the biological factors, but also you're looking for the psychological factors and the social factors. So the other important also risk factor, the operative factors, when the duration of the surgery is more than 3 hours. Some surgical hospitals that they don't have a lot, the surgical volume is slow. Surgical techniques definitely, and redo surgeries, history of redo surgeries. Patient come for a knee replacement, revision near the 3rd or 4th or 5th revision. Spine surgery, the 3rd or 4th revision of the spine surgery. When the surgery in the nerves and there is a nerve injury, also this is high risk. Most of us anesthesiologists, and we're looking for anesthesia risk factors. There is no consensus. There's some evidence, but very weak, that using inhalational agent, using remifentanil can increase this risk. As I mentioned before, the risk or the incidence, according to the type of the surgery, is very variable, but I will give you like the majority or the big percentage of patients with amputation, thoracotomy, knees are like one of the highest risk. Definitely you add the spine surgery, but it's another category of patient that some will maybe put the lumbar post-laminectomy syndrome under this category, other would not put it there. Post-operative factor. The post-operative factor, the intensity of acute post-operative pain. When you see the patient in acute pain as an acute pain physician, for example, in the post-operative period with a lot of pain, catastrophizing, anxiety, use of opioids, and even use regional anesthesia, catheters, and he's still in pain. You know this patient will develop chronic post-operative pain. In pediatrics, kind of the same risk factors, but they add in it the parental pain catastrophizing. If the parents catastrophizing also, this put the patient himself or herself in the risk. So this is a summary of the risk factors. And as you look, a lot of them that are non-modifiable. You can change, you cannot change it's a female or it's young. The surgical procedure, it is kind of maybe modifiable to ask the surgeon to change it, but realistically, it's not like applicable. One of the modifiable risk factor is psychologically by a preoperative psychological interventions like we can discuss later. So this comes into questions, okay, I know this patient is going to develop because he have a lot of risk factors. So can I have a predictive model to identify these patients, and then we can act upon this. So it's a key, because you cannot manage, or you cannot have a transitional pain, or you cannot see all patients that go for all surgeries. So there is many work in trying to have a predictive models using the previous work that I mentioned, and also a lot of composite biomarkers and machine learning algorithm. But those predictive models are still early to be adopted in a clinical wide use. And there's a lot of apps in the development. You put the patient information in the app and they give you a risk. Once you identify those patients, a $1 million question comes. Can we prevent? How to prevent this chronic post-surgical pain? The quick answer, it is very difficult because there is no strong evidence of a one modality versus other that it can prevent, because it's a very complex biopsychosocial phenomenon. It's not only biological, like I will mention. After that, there is a lot of interventions and a lot of studies that we're going to see that not lead to good outcome, because it's not only biological, it's not only the incision and the inflammatory reaction, and you're going to do certain type of injection and you are good and you're preventing the chronic pain. It's a psychological, also it's a social issues, so it's a social issue. So we'll go to some of the pharmacological and interventional with possible solution and also preventive strategies. There is a lot of them, so we'll go just through them very quickly, and I will leave you with some of the references that you can look into them. For example, like the anti-inflammatory drugs, just the non-steroidal. There is some evidence, it's not that strong. Tylenol, we use it all, pre-operative, post-operative, but amazingly, there's no evidence for it. Corticosteroids, there was a lot of hope that because it decreased the inflammatory cascades and decreased the central sensitization, but the evidence is very weak. Opioid, usually you want to avoid it, especially the fentanyl. There is good evidence of using intravenous lidocaine. There's a lot of interest in ketamine, and we have studies like with NIH using the ketamine, but still the evidence, it's not that strong. Using nitrous oxide, there's some possible preventive effect. Using the anticonvulsant medication like gabapenoids, Lyrica, the gabapentin, there was a lot of promise, a lot of studies, it was positive, but usually with the higher dose. When you give a higher dose, it comes with a side effect. And with the recent meta-analysis, did not show a significant effect in the outcome. Lyrica actually, and amazingly, have a better outcome and better evidence up to 6 months in preventing the chronic post-operative pain. Using alpha-2 agonists like clonidine, dexmedetomidine, using topicals with different types of medication. So this review article, relatively recent, summarized the evidence regarding the pharmacological use of those medications. Look to the image or the infograph in the left side from the article, and I have give thanks to Dr. Schreiber for the excellent work that she did. That corticosteroid, there is no evidence. And even the placebo may be the same or better. The ketamine use, the gabapentin, it have some evidence up to 6 months. Lyrica, the IV lidocaine, and used non-steroidal have a stronger evidence. So when you look to the cascade from the surgeon, the image from the right side, from a surgical incision to the spinal cord to a central sensitization, there is many opportunities in many areas that you can interrupt this pain pathway and lead to better outcome. All of us, or the majority of us, like to do intervention, regional anesthesia and other advanced procedures. Again, the evidence, it's not that strong. Theoretically, mechanistically, it makes the sense that you block the transmission of the nociception and decrease the inflammatory input. You reduce the opioid use, which increase the issue with the chronic post-operative pain. The majority of the evidence with the epidural analgesia, also some evidence with the peripheral nerve blocks, paravertebral blocks. Unfortunately, it was negative with the recent study with Dr. Sessler. Continuous use of a peripheral nerve block, like inserting a catheter, and continuous infusion also make sense. Again, the evidence is not that strong. It's not a gold standard. There will be many factors. Using a multimodal pain regimen, so you don't depend on one regional technique, or you don't depend on one modality or one medication. You combine the gabapenoids, the anti-inflammatory medication with Tylenol, and use a form of regional block, and then continue seeing the patient after that. I think this is the best combination, and there is some evidence about the multimodal pain regimen. This table summarizes many of the studies regarding use of regional blocks in different kinds of surgery: breast thoracotomy, cesarean section, inguinal hernias, and amputations. You look to the left corner, that studies that it in favor, and there is a studies that it was not conclusive, and in the same category of patient, studies that showed a negative outcome. So it come up with like a confusing result. So do we have to use a paravertebral block, or all breast surgery to decrease the chronic post-operative pain. I mean, we're going to have a discussion later, but no one single modality can help a very complex situation. So it's a very complex, it's a multifaceted or multi-aspect, multi-dimensional issue. So it should be managed also by a multi-dimensional solution. No one simple solution can fix a very complicated. Other also a very important measures that you can take to treat and prevent such an issue is, for example, wound infiltration, use minimally invasive surgery. You can advise the surgeon to use less invasive techniques for surgery, and it's very difficult, but it is possible. Again, there's no gold standard, even with the laparoscopy versus open procedure. Even with the laparoscopy, the incidence of chronic post-operative pain, was not less than the open procedures, amazingly. Psychological interventions. So I'm not a psychologist, but I have to stress out the very important role of the psychological interventions that can be done to the patient preoperatively, immediately post-operatively, and in the chronic post-operative stage. Many techniques can be done to this patient, from biofeedback to cognitive behavioral therapy, adding a non-medication option like music therapy and relaxation technique, acupuncture. It can have a role. And I put this like a retrospective review study that even just engaging with the patients, meeting the patient preoperatively without offering any medication, without offering any interventions, no needle, no even a single change in his medication, just talking to the patient, what his expectation, what he's going to do the surgery, and we're going to give him whatever medication that you can plan, regional blocks, IV medication, just talking to him actually lead to less use of opioid therapy. Many interventions are used in the treatment of chronic post-surgical, but theoretically, some of them can be used as a preventive measures. Cryoanalgesia, radiofrequency ablation, neuromodulation techniques. Again, because of the time, we cannot detail all of those technology that available. I will just touch base on some of the procedures, some of the techniques that can be used in interventional in the treatment and prevention. Also, I stress out the prevention of the chronic post-operative technique. In US, we have a simple peripheral nerve stimulation. It's approved and used for 60 days. It's a coiled lead. It's inserted with X-ray or ultrasound. It's very easy or very quick during the insertion, and the procedure itself is very simple. Regional anesthesiologist and definitely a chronic pain physician can implant this. It can be inserted preoperatively, you can insert it postoperatively, and you can keep it for 60 days, provide you analgesia for multiple targets. It has a lot of use in many studies. I just put some of them. It has been used in the knee replacement surgery, in shoulder. It also used for ankle surgery. So there's a lot of use and a lot of evidence. And when you look to the peripheral nerve stimulation scientific evidence, number one evidence is related to the temporary 60-day stimulation of whatever target you choose. There is also other role in the cryoanalgesia, and it have use in acute pain and also subacute pain. I put just a nice review article in Physiology. You can read this. And also, especially as a treatment, a dorsal root ganglion stimulation is even mentioned in the literature to treat the chronic post-operative pain. There is a lot of potential for the future in that area. I will give you some like early work that some and myself did it in this area. Again, we're especially related to peripheral nerve stimulation. So you can put an erector spinae around the dorsal rami before spine surgery, after the spine surgery. And one of the stabilizers muscle of the lumbar spine and also can help with the abdominal surgery is the transversus abdominis muscle. So if you stimulate preoperatively and postoperatively the transversus abdominis muscle, potentially you can decrease the preoperative and postoperative pain for the spine surgery and also for abdominal surgery. Shoulder, one of the very common surgeries that we do, and patient have postoperative pain, chronic postoperative pain, doing a preoperative, postoperative RFA for the distal sensory branches without affecting the motor function, definitely without affecting the phrenic nerve. Also, the same sensory branches are targets for peripheral nerve stimulation implants, post-operatively especially. Spine surgery is also considered like a huge part of the population that we deal with, doing a block preoperatively, like thoracolumbar interfacial blocks, cluneal nerve blocks, and also peripheral nerve stimulation considered as a target for those patients. And cluneal nerve blocks, you can block them above the iliac crest and also at the L3 level, just lateral to the erector spinae muscle, where the origin of the cluneal nerves. So there is a great potential, as I mentioned, in the shoulder articular branches, in the cluneal nerves, as you see in the images above the iliac crest, or you can do it at L3. For abdominal surgeries, for a knee, you can do preoperative geniculars, RFA. We do sometimes preoperative genicular or femoral peripheral nerve stimulator implant, just as a preoperative preventive measure, and you continue using those peripheral nerve stimulator for postoperative care. When you go to the more chronic stage, and unfortunately the patients have a chronic 3 months and then beyond this, especially if the pain lasted to 6 months to 1 year, this will come the role of a permanent implant on those patients with the use of ultrasound and also with a lot of evolution of many types of peripheral nerve stimulators that are minimally invasive, small. It's like the peripheral nerve catheter using regional anesthesia, but a little bit more advanced with leads, but it's very simple. It's not a very complicated surgical procedure without even a battery. So with the neck, for example, have a posterior cervical fusion. With occipital headache, there is also potential to do a great occipital nerve stimulation, and you look to the image to the left, using ultrasound, use X-ray for the hip, and also pelvic fracture. So potentially you can put a peripheral nerve stimulator in the sensory distal branches of obturator and femoral, and also posteriorly around the posterior sacral nerve. With the cluneal nerves, you can implant, especially post-lumbar fusion laminectomy at the iliac crest or even higher. With shoulder and also for cervical, you can put the C5, C6 upper nerve root trunk stimulator. For the thoracic, you can implant for cases of thoracic laminectomy or post-thoracotomy, either like a DRG or even a dorsal thoracic rami. And in the look to the image, even we implant at the lateral cutaneous branches around the serratus anterior muscle, permanently implanted devices to treat chronic postoperative pain. So one important point that the chronic pain or the post-injury pain, it's not only a surgical population, because many other can develop a chronic pain after an injury, and the incidence is high. For example, the knee pain, hip pain, post-herpetic neuralgia, many types of the headache, abdominal pain, pelvic pain. Those patients have a sort of acute injury, and they have subacute pain, but they are managed by non-pain physician. So also early referral for those patient population to us, it will be valuable. So it's not only the surgical patient, the surgical patient is more easily identifiable, but other non-surgical patients also come into play here. So the question comes into, can we really prevent it? And there's many measures, as we mentioned, it can be used preoperatively, and you can continue after the discharge to decrease the sensitization. Because a lot of us see the patients in the hospital with the regional acute pain team, they put a plan, and then after the patient will be discharged with a non-individualized regimen. And there is no subsequent plans, how to manage this patient, who to manage it for, how long, and lead to the chronic pain post-operatively. So can we prevent that? Can we take a preventive, then be a reactive, a preventive action? So I will just try to define like the primary prevention, secondary, and tertiary. Primary prevention, that we want to prevent the pain before even it happened, before the acute pain is happening, which is very challenging, and it's kind of a general population health issue. The secondary prevention of what the core of what we're discussing today, that you're gonna know this patient, you're gonna may develop chronic pain, and you want to prevent the transition from the acute to the chronic pain, which many names can come with it, like subacute pain, persistent chronic post-operative pain, transitional pain, you can name it as you want. The tertiary prevention is what we do. You are in your chronic pain office, patient already have pain for a year or whatever, and then it will come to you. You want to decrease the severity and the frequency, but it's already happening. So your main goal is secondary prevention here. And as you see, there is a big gap. And it leads to costs, direct medical cost, indirect medical cost. So it's very costly with the evidence of thousands of dollars, it definitely in addition to the quality and the suffering that the patient have. So this is kind of the classic pain continuum or pain service that the majority of health systems have. You have a preoperative pain and in-hospital acute pain service, and then the patient doesn't have a follow-up of full discharge and come to us in the chronic pain offices with a chronic pain late. So there's a gap that it needs to be filled. And this gap is well known for decades, but there was very few centers that started to establish such an organized service. So I have to give a big thank and a big gratitude to the Toronto General Hospital, Dr. Clark and his team, who has pioneered this and started this a while ago. What they established a very well transitional pain service. Follow that, there is many US centers that have such a model with different ways how to do it. The Duke, Hopkins, Vanderbilt, and the VE Hospital in Silver Lake City. And I have the opportunity to work with Ezra to establish like a special interest group focused only in the chronic post-operative pain. And we had a lot of effort that done lectures, podcasts, publications, and we did 2021 a whole symposium, lectures and about only chronic post-operative pain. And as Dr. Siddiq mentioned that next Saturday, we have a whole symposium, chronic post-operative pain symposium, our second one. It's next Saturday, March 11. So I encourage you all to log in, and we'll send you the link and participate. So it's a whole day because the subject is very complicated. During the symposium, you can have a very world experts in multiple areas. They're going to discuss all the basic science behind the transition from the acute to chronic pain. They're going to discuss way of prevention, ways of treatment, from addiction, from psychiatrists, psychotherapy, interventional aspects. We're going to have a whole session about peripheral nervous stimulation implants. And then we're going to have workshops. And it's a virtual, but you can have a lot of workshops with ultrasound and also fluoroscopy, many targets. So you're going to see and listen those workshops and demonstration, and then you're going to have the opportunity to interact with those world key experts, asking questions directly, interacting during the whole symposium, and the whole symposium will be recorded. So if you're not able to log in the same time of the symposium, you can have access to all the lectures. You can download them. You can see all this lecture for the whole year. So I encourage you to go there. It will be very useful. It's worth the money, as you say. So one of the efforts also, we try to improve the research, and we publish many guidelines how to establish a transitional pain service. So I encourage you to go, there's many resources there. So the idea is very simple, and it's not like a rocket science to develop such a model. So because you want to provide a continuous approach, you want to see the patient preoperatively, postoperatively, to manage the whole medication, the post-discharge, and to improve the patient functioning, not only pain. You have to have outcomes when you establish such service, and those outcomes should be measurable, and should be measurable with amount of dollars, with money, to prove not as a quality improvements and to improve the patient's outcomes, but also for the hospital. You have to show them that you're making money out of the service. You can prove to them that you have a shorter hospital stay, you're weaning the patient from opioid, you improve the patient quality and decrease the stress, and reduce the incidence of post-operative pain. So it's very simple. Again, you have to have kind of a referral criteria to see some patients that with high risk, meet them preoperatively, and formulate plans with them. Short-term plans, long-term plans with the patients, and communicate with the anesthesia team and regional team what you're going to do preoperatively, types of blocks, medication, post-operatively. See those patients post-operatively while in the hospital, and see those patients after the discharge in your clinic for a certain amount of time, up to the patients or up to the whatever the health system will allow you, up to 6 months or even more. The team, it's variable. You can have an anesthesiologist, psychologist, nurse practitioner, physical therapist, and the core that the anesthesiologist or the physician who's in charge of this, he have to have some sort of experience from the acute and chronic pain. He doesn't have to be expert in both, but at least have some interest in the other. If he's chronic pain physician, he has to sort of experience and some expertise in the other, the acute pain side. So this is simply the pre-operative to post-operative and chronic post-operative pain. It is a collaborating effort. There is no one know all those aspects. There is no one physician can manage the mental health issues, can manage the addiction, can manage the acute, can manage the chronic. So this comes with collaboration. It is the key of a success of this pain service. So it's not about one medication that you're going to change and the patient will be magically good. It's not about you doing a paravertebral block for mastectomy and there's no issues post-operative and the patient is happily ever after. No, it is multi aspects. That's how you're going to succeed, and that's how you're going to improve the patient's outcome. So key, and also this to improve your financial aspects, that you cannot see all patients. You have to have a referral criteria, and you can customize those referral criteria and make it easy to capture those patients, because it's all about money, as they say. So you have to have a good business plan for your service to send it to your leadership to approve it, so you can implement this in your hospital. We published this 2 years ago, where we have many hypothetical scenarios of how you structure your service and how you can improve the outcome. So simply in a y-axis, if your savings to your hospital exceed the cost, so you're going to make a profit for the hospital. So you have to have kind of at least 2,000 surgical patients in your hospital to make it financially profitable. There's a lot of hypothetical models in the study. I mean, again, it's beyond the time of the lectures, but you can see the how we analyze it. So you have a business plan to present it to the leadership to have such model of care in your hospital. And it's very important because it closes the gap. But again, there is a big gap, as we know, between the acute and the chronic. And in each point in our pain continuum, from the acute to the chronic, there's many levels of expertise that needed to fill this gap. So someone will ask, do you really need a dedicated service and a dedicated staff in your hospital? Their only job is just only transitional pain service? I will give you an ideal world. The clear answer is yes, definitely you need this. But realistically, this is very difficult to have it, especially with a lot of economic pressure, productivity, with the majority of health system across the world. So I see it as an evolution of the acute and chronic pain. So the acute pain service should be evolution to take some of the responsibility in this chronic post-operative pain, and also the chronic pain services team have to take some responsibilities and go back to capture those patients. How you can do that? I mean, again, simply early stratification, identify those patients and early on send the consultation to your colleagues from addiction to rehab to chronic pain. If you're not chronic pain physician, it's about multidisciplinary, involving psychiatry, rehabilitation, and use the existing resources. This is a key to success, because the majority of health system, they are overpressured with the costs. So it's very difficult to go to them, ask them that you need 10 staff just only to do the transitional pain service. It's not realistically possible in the majority of the health system across the world. So use the existing resources and give them an outcomes that can be measured in dollars, length of stay, the satisfaction, if there's a certain scores that it's measurable. So it'd be useful, and focus in high-risk patients. Focusing in high-risk patient will help you, and try to nest this within the perioperative surgical home model if you have it, and within the acute pain service, within the chronic pain service that you have it in your hospital. So use the existing resources, use telehealth, and the future may use machine learning to try to improve the cost effectiveness of such a model. So I close to be done, but as I say, there's a gap between the acute and the chronic pain generally in many areas. So it's not only about the transitional pain service. This gap, there is other opportunities for all of us, and it's up to all of us to close this gap. Education, for example. I mean, there is acute pain fellowships and chronic pain fellowships in US. There's a big value of having a dual fellowship in both the acute and chronic pain. If this is not possible, have a service in your hospital with both acute pain physician and chronic pain physician or together. Each one have a different experience. Each one would contribute by a different way. Having both in the same team would be very useful. I would urge the chairs and the patient and the physician who have a leadership role to fund fellowship or fund even a special training for any interested staff in that area. Having elective, going to a conference, it will help. Because a lot of chronic pain physicians, for example, are not comfortable with ultrasound. They are not doing a nerve blocks and interfacial plane blocks. So having the experience from the acute side to go to some of the chronic pain physician in that area would help. The X-rays, the fluoroscopy, and a lot of advanced procedure and advanced neuromodulation procedure that acute pain physicians are not comfortable. So cross-training between both sides, it would help. And I stressing out to help decrease closing the gap, the collaboration. Using a multidisciplinary approach, as I mentioned before, there is no one easy solution to serve this patient. And this is one of the big reasons that a lot of studies what you look confusing. You can see a positive result and a negative result from the same procedure for the same surgery, because it's just a one simple intervention used for a short time. So it is a continuous relationship with the patients, not one injection, not one visit. It's a continuous and also multi aspects. So you have to collaborate and you expand the education with the substance use disorders, perioperative medicine, the research in academics. We have the NIH, they have a lot of interest and millions of dollars put by NIH in the signature program to tackle this issue with the transitional pain service. And I will urge the research to go beyond just the risk factors to how to have a transitional pain, especially financially feasible. And so we have to change the mentality of us as a physician, pain physician in general, from treatment to prophylaxis. We need to be a preemptive, a reactive, that we know this patient is going to have an issue. So let's take an early action. Societies and meetings, I don't like to see societies in two different words. The acute pain have a different meetings, different attendees, and the chronic pain meetings, they are like totally different, and the gap is going more and more. So I see it, the traditional acute and chronic pain physicians, they are like in the old side, and what we should try to have a transitional, and it's still in the early development, like still like a little kid grow up in that area. So it's an area of need, an area of a big gap in our pain care continuum, which will create an opportunity for us to advance the practice and advance the research. And this gap need to be filled, even with the established acute pain and established chronic pain. Still this gap is there. And I believe that the field will evolve. It will take some time, and it will become a necessity, especially in a big hospital settings, to go in that area. And it's inevitable, it may be inevitable to develop like a new subspecialty, I can say for that, and to fill this gap. The research advances. There's many research studies over the years about this area, but our practice, our daily practice, is still lacking behind. And in the big health system with a big number of patients and surgical procedure, I think it's a necessity. It's not a luxury. We're still in the early, but we're making a good steps forward. So I will thank you again. I mean, I'm done with the main topic. I mean, the topic is big, so happy to take questions, and I will urge you all to be more involved. And as I mentioned, the next week we have a whole day for 8 hours just talking about this subject.
Thank you so much, Hesham. That was fantastic. I think we do have some questions. There's a question from Adil Milad asking, he says, thank you very much for a wonderful lecture. What do you think about hypnosis, pre and intraoperative, or any evidence on virtual reality education for high-risk patients?
A very good question. I mean, I thank you very much for opening this question. So this go under a big umbrella, a non-medication option or non-interventional option. Mechanistically, it can be useful, but evidence is very weak. Very few reports of using the hypnosis or the virtual reality. There's many companies also using music therapy, and there is some work in that area. The evidence is very, very primitive. But what I see, what I asked and answer this in this point, that if you have the opportunities, if you have the luxury of know how to do the hypnosis, or you have those devices available, do it. It's a very low risk. If there is no issues with the cost, there's no very low risk. I mean, simply like there is no side effect in this. So if it doesn't help, it will not hurt. But the main obstacle, I mean, the availability and the cost.
Hesham, I have got a comment actually. So talking about virtual reality, it's a work in progress, especially at Cleveland in Abu Dhabi. We are going to roll out virtual reality for procedural pain management. I think TPS will be the next thing. And the other thing is we are currently working on the newsletter. I think Azra newsletter is going to come out soon. And we're working on a special article on virtual reality. So watch out this space, guys. I think whoever wants to know about virtual reality, I've got a lot of interest in virtual reality. I did virtual reality in Leicester as a part of my kind of project. I was doing an audit for procedural pain management. So when you're doing chronic pain blocks, instead of giving sedation like midazolam and fentanyl, you actually use virtual reality goggles and put them in the virtual reality environment. So you could actually perform the procedures with very minimal discomfort. So I just thought I'd make a comment that that's work in progress in this part of the world. So
thank you. It's great. Yeah, it's great.
So we have another question from Amit Verma saying, do we have any data suggesting cost effectiveness of transitional pain service? So any data on that? Like, when you said you have to talk to the managers and show them how it's making a difference. So do we have a data on
very good question. There is no data like prospectively, like just based in hypothetical models, not a real numbers of transitional pain scores that established before and after, because the cost is very complicated, and in US especially there is a lot of discrepancy between the one who get paid, but the hospital get paid separately than the physician. So there's two separate entity, and also the big health system, and depends if you're university, or you are in a private practice, or you are a non-profit organization. So to have a real dollar number is very challenging, and there's many inputs in the equation that you cannot really calculate it by amount of dollars. So there is like hypothetical models that if you did the service and you decrease the cost of opioids, or you decrease the visits, and each visit will cost X amount of dollars, and the opioid use will cost you yearly $5,000, $4,000. So by just decreasing the incidence by even 10%, you will save X amount of money.
That sort of makes sense, to be honest. Hesham, I have a question. Now, when you talk about application of transitional pain service, is there a work in progress in terms of having recommendations or guidelines for particular surgery, like, breast surgery or knee replacement surgery or hip replacement surgery? I know it's a service, but do you think that a time will come where we'll have said, this patient has this scoring system, shows his high risk, so this is what we're going to do, get them to have a couple of sessions with hypnotherapists or VR, and then they're going to have a medication regime given to them pre-op, and they're going to have post-op, intra-op, going to have nerve blocks. Post-op, they're going to basically see the pain team 3 times and then get referred on to the pain clinic to come and see the pain physician in 2 months or 3 months. Do you think, is that going to be like the work that's going to be done in future? Like the prospect guidelines from Ezra, every surgical procedure has some kind of recommendations, but they're mostly recommending based on the enhanced recovery pathways, but not from chronicity point of view. Nobody's actually talking about, okay, what happens to these patients in long run. So do you think that's something that's going to come up in near future?
Excellent question, Sidi. Thank you very much. I mean, this is a very important point. Thank you for saying that, so asking me these questions. Have been work trying to really have a strict guidelines for each procedure, what you're going to do. I will just throw a knee replacement. If the patient have certain risk factors, 1 to 3 for the knee, and you're going to do for them preoperative peripheral nerve stimulation, preoperative gabapenoids, intraoperative injections, post-operative follow-up in the acute pain service, you're going to do this and this. So kind of like a standard guidelines. There is some trials of that by the Toronto group. It's not like a really standard as Prospect or in other areas, as you mentioned. And I think it will not be even in the future something like this, because there is no gold standard of any closed procedure. The evidence is not strong in, because you can find 10 studies saying that you have to do epidural, another 10 studies that you don't. Studies that you have to do paravertebral, and another equal study that you don't have to do paravertebral. And very important factor that there is also availability. Let's say if you want to put a peripheral nerve stimulation for each patient with knee replacements with a high risk, the insurance may say no, the patient will say no. The availability of expertise in implants, it may be not available. So it's a little bit too early to have a standard regimen for each type of the procedure. So I would say that customize it to the level of expertise and the availability in your hospital. You're going to definitely find a medication that you are comfortable with. You can definitely find a sort of intervention that you're comfortable with. You find a psychologist that you can see those patients if needed, find a physical therapist that you can see these patients, and then you can use those resources. Whatever available, you can use it.
I think this webinar is very timely. As you said, next weekend, whole day of persistent post-operative pain, and knowing about what services could do in terms of acute pain and chronic pain to help these patients, and minimizing the chronicity is what I'm looking forward to. So Hesham, I would appreciate if you can just send me the link. I'm going to pass it on to all the guys in the group, and also we'll put it on the Facebook and the LinkedIn so that people can also access it over there. So thank you so much. I don't think we have any more questions. We do have one question. Sorry, I forgot. This is saying, do you think position of psychology or psychologist is essential with the theater team, as well as ICU and palliative care medicine service, like pain centers, especially for those high-risk patients? So, given that you already mentioned the importance of psychological kind of comorbidities and chronicity of pain, do you think we should have psychologists? Not every pain service can afford it, but what's your take on it?
100% yes. 100%, 200% yes. Psychologists, doesn't have to be psychiatrists, is a key role in such success of a model. There's a lot of psychological components of this problem. I say the majority of those patients need a psychologist. If it is not available, I mean, you can send them to other psychologists that you work with, and also you can do it as a tele. There is a lot of resources by virtual. I mean, the patient can meet the psychologist virtually. Even preoperatively, postoperatively, he doesn't have to meet him in person if this not available at your hospital. The other, like addiction and rehab, and as you mentioned, the palliative, it is also important, but the psychologist is essential.
And I think COVID changed our way of dealing with patients, right? Telehealth is so now commonly used in various parts of the world. So you don't have to physically bring the patient in the hospital. You could basically talk to them over the computer and educate them and give them a cognitive behavioral therapy session on the phone or on the computer. So it is possible, I think. Once again, thank you so much, Hesham. That was fantastic. Really appreciate you giving us your valuable time, especially on Saturday. So guys who have joined, I've recorded the webinar. I'll put the webinar recording on the YouTube channel of Pain Talks Education, and also on the Facebook page. And look forward to tomorrow to see you guys on the webinar on cervical spinal pain management by Prof. Dominic Hegati. So see you tomorrow. Thank you so much. Thanks a lot. Thanks
very much all.
Have a good
Thank you. Appreciate it.
Take
My
care.
pleasure. Thank you
Bye-bye.
very much all.
Thank you.
See
Bye.
you all.